Hello friends, welcome back to Cortex YouTube channel. Yesterday I have asked a clinical case scenario in my Instagram handle and I got various different answers. So I thought let me make a video on this and clarify the doubts. So here is the question. A 78-year-old male with recent symptoms of lightheadedness and one episode of syncope. The ECG is given below. Interpret the ECG. So ECG, whenever you start interpreting the ECG, first thing that you have to make sure it is whether it is taken properly or not. Technical errors should not be there. So how to know? First thing that you have to say is standardization. Standardization means the speed, the calibration of ECG paper. Okay, so it is taken at this ECG is taken at 25 mm per second and 10 mm means 1 millivolt. This is a normal standard. So this is normal standard. Then you have to see lead number 1 and AVR. Okay, if both are positive, that lead number 1 is positive, lead number AVR is negative, means it is taken properly. So lead number here 1 is positive. Positive means predominantly upward and AVR is predominantly negative, so it is taken properly. So there are no technical errors in this ECG. Next thing that you have to see is rhythm. So how to know the rhythm? So for that you have to see three things: whether all the all the P waves are normal or not, that is P is equal to P. Then all the P wave is followed by QRS or not, that also you have to see. Then whether there is RR interval is regular or not, so RR interval is equal to RR interval or not, you have to see. So in this ECG, if you look at carefully rhythm strip, this is your rhythm strip. So RR interval looks normal, that is around 7 boxes each time. So but there are no P waves are not there, so it cannot be sinus rhythm. So look at this, P wave is not there. Then what happened? Then so RR interval is regular, so rhythm is regular but P wave is not there. Okay, so rhythm here is regular. Then you have to calculate rate, what is known as rate. So rate, it is easy to calculate once you know the distance between two R waves. 1, 2, 3, 4, 5, 6, 7. Around 7 big boxes. So you have to divide 300 by number of big boxes between two R waves. 300 divided by 7 means how much it will come? It will come around somewhere around 43. Okay. So it's around 43 beats per minute. So definitely it is less than 60. So it is definitely bradycardia. So one significant abnormality that we got in this ECG is bradycardia. Next thing that you have to calculate is rate. Rate, after rate you have to calculate the axis. Axis, for that simple way is you have to see lead number 1 and lead number AVF. And in that you have to see QRS complexes, whether they are predominantly upward or predominantly downward. So here lead number 1 is this. So here it is predominantly up, as I already told. And lead number AVF, here also QRS complex is predominantly positive. So both are up means it is normal axis. Okay, those who are listening this video for the first time, let me also tell them, if lead number 1 is positive, that is predominantly up, and lead number AVF, that is lead number AVF, it is negative, predominantly negative. So both are leaving each other, one is going up, one is going down, it is so leaving each other. L for L, left axis deviation. One is down, AVF is up, that is one AVF is positive, one is negative, both are reaching each other. So R for R, right axis deviation. If both are negative, it is extreme axis deviation or indeterminate axis. So that's about axis. In this case it is normal. So abnormality so far we got is no P wave and bradycardia. So in ECG interpretation there is a rule of 4. What is a rule of 4? Here first 4 things are your history, rhythm, rate and axis. Next 4 things are waves, P waves and QRS complex, T wave and U wave. Next 4 things are 2 interval and 2 segments, PR interval, QT interval and PR segment and ST segment. So let's look at the waves now. There is no P wave. P wave is absent. And look at the QRS. QRS looks normal and normal duration, that is well within 120 milliseconds. Look at this. QRS is normal. It is not wide, it is not notched. Every QRS is normal. Okay, QRS is narrow or normal. Then T wave is normal. There is no U wave. U wave is not there. Next, intervals, and since P wave is not there, PR segment, PR interval cannot be calculated. So we calculate what is known as QT interval. So QT interval, corrected QT interval for this patient is, there are so many formulas to calculate corrected QT interval. So how to remember them? So these formulas are very boring. So boring formulas for heart. So this is the mnemonic, boring formulas for heart, where B stands for Bazet's, F stands for Fredericia, and F stands for Framingham's, and H stands for Hodges formula. Bazet's formula is most commonly used, which goes like this. It is QT interval, that is calculated by ECG, given ECG, divided by the number of, square root of RR interval. So this is the formula for Bazet's QT interval formula. So here, if we calculate in this case, it is QT interval here comes 0.52 seconds divided by number of RR interval. RR interval comes around 1.48 seconds. So if we calculate, it comes around 427 milliseconds or 0.42 seconds. So this is the corrected QT interval in this patient, so which is normal. So QT interval is also normal. There is no ST segment elevation. So what are the abnormalities so far we identified? That is, the first one is bradycardia. Next is absent P waves or no P waves. So rest other things appears normal. So bradycardia, you should know what are the causes of bradycardia and what are the causes of absent P waves. So let's look at the causes of bradycardia. Is bradycardia normally seen in normal patients? Physiological causes of bradycardia. Yes, bradycardia can be seen in normal patients during sleep and in persons who are athletes and elderly patients. Okay. And what are the diseased condition or abnormal conditions that presents with bradycardia? One is inferior wall MI, endocrine causes like hypothyroidism, and Addison's disease. Then your obstructive jaundice, raised intracranial tension ICT, then hypothermia. Okay, so these are the abnormal conditions that presents with bradycardia. Here I would like to give ECG clues to identify these causes. In inferior wall MI, there will be ST elevation in 2-3 AVF, that is your inferior leads. Okay, in this ECG is not there. And hypothyroidism, you will get low voltage complexes also. In obstructive jaundice, obviously clinically you will see icterus present. In a raised ICT, Cushing's reflex, there is a high BP, irregular breathing will be there. In hypothermia, Osborne waves will be there. So these are the clinical clues that you have to identify whenever you get bradycardia. Then what are the drugs causing bradycardia? So they can be easily remembered by A, B, C, D. So A stands for amiodarone adenosine, B stands for beta blockers, C stands for calcium channel blockers like verapamil and diltiazem, D stands for digoxin, and one more bonus drug is ivabradine. Okay, so these are the causes of bradycardia that you have to know. So in this question, they have not given the history of medications, chest pain, icterus, endocrine diseases. So these are unlikely. And here, patient is not athlete and he is not sleeping. So maybe because he is elder, so he may be having bradycardia. In elderly, it's mainly because of degeneration of a SA node. So SA node dysfunction or sick sinus syndrome can cause bradycardia. And let's look at the causes of absent P waves in ECG. So whenever you approach to absent P waves is, whenever you get absent P waves, you have to see the rate whether it is less than 60 and whether it is more than 100. So if it is bradycardia and if it is tachycardia, what is your approach? If it is tachycardia, you have to see RR interval, whether it is regular or it is irregular. If it is irregular, obviously you know the cause, that is your atrial fibrillation. If it is regular, it is PSVT, that is your paroxysmal supraventricular tachycardia, narrow complex tachycardia, regular tachycardia. So there also you get absent P waves. So what if the heart rate is less than 60? When heart rate is less than 60, what you have to see is QRS complex, whether it is wide, whether it is normal or narrow. When I say wide, it means it is more than 120 milliseconds wide. Okay, if it is wide, you have to suspect hyperkalemia. If it is narrow or normal, you have to suspect sick sinus syndrome. Here, when sinus node is not functioning well, it's not working, so it is not producing the electricity, so someone else will take over the charge of SA node, that so and produces and acts as a pacemaker and produces electricity. So in this case, it may be AV node which is producing electricity, which rhythm or rate may be 40 to 60. So in this case it is 43, so junctional rhythm could be okay, but in junctional rhythm you may get inverted P wave. So in this absent P wave is there, so it may be sick sinus syndrome. So far our interpretation and diagnosis yields to sick sinus syndrome or sinus node dysfunction. In elderly, sinus node dysfunction is common because in elderly there are a degeneration of all the cells, almost all the cells, like neuronal degeneration and so many cells. So similarly, SA node will also get degenerated, so resulting in sick sinus syndrome or sinus node dysfunction. So this ECG talks about sinus node dysfunction. Hope you learned something from this video. If so, please like, share and subscribe, and please share this among your friends, juniors, colleagues. Thank you.